23rd, 2018, here on the HCMA Facebook page, and we welcome all of our viewers from all around the world. And today we are going to bring you a Meet the Experts segment. And in just a few moments, I will be bringing our expert on camera with us. And today we have Dr. Iacopo Olivotto from Florence, Italy, joining us. Just as a reminder, these programs are meant for educational purposes only. If you have any individualized questions about your HCM care and management, we recommend you speak to your personal physician or identify an HCMA recognized center of excellence for your care. During the question and answer portion of today's segment, we will take general questions about HCM and be happy to address them for you at the end. So if you have any questions, you might want to think about them as we're going and type them in. So when we say send your questions, you're able to do so. So welcome, and I'm going to share the screen with my dear friend, Dr. Iacopo Olivotto. Welcome.
Thank you, Lisa. Thank you, and hello, everybody.
It's so nice to have you here today. I feel like I've known you forever and ever, and we realized as we were preparing for this interview that we've both kind of been in the HCM scene about 23, 24 years.
I shouldn't say that. It makes me feel old.
I know, it makes us both feel old.
It's so fast, yes.
So tell us a little bit about your background and where you're from and the center in Italy.
So I originally trained in neurology at the University of Florence after my graduation. Then I moved to London for about a year and a half, and I realized that the brain was too difficult for me. So I better concentrate on an easier organ, and that was the heart. So I really fell in love with cardiology. So when I started working in cardiology there most of the time with heart failure. And when I came back to Italy, I looked for a job, and there was the only job I could find right away was an emergency room job, which I took, and I met Franco Cecchi, who set up the program here in Florence, and I began working with him. And so my passion grew, and then as soon as I could, I moved into cardiology full time. In 1995, I met Dr. Mera, thanks to Franco, and so we started digging out all our data and exploring HCM. It was really prehistory at the time, Jurassic Age. But and since then, I've made in numerous trips to the US to work with all the major experts, and we had this program really grow. And now, in 1995, we published the first paper in ZPak with 202 patients, and now we are approaching 2,000. So it's really been quite a steady growth, and the passion has grown as well.
So 1995 is also the year that I met Barry Marin. So I don't know, maybe you're my Italian brother and we didn't know it. Okay, so you got first involved with HCM because you started working with Franco Cecchi, who I met at the first International Summit on HCM in Minneapolis all those years ago. What was HCM? I'm going to go off script here a little bit. What were you thinking about HCM back in the mid-90s? And we'll talk about where it's gone to today. What did you think the disease was back then?
Well, interesting question, because in fact, at that time, the disease was thought to be very rare and very malignant. So because, of course, only the very serious cases were picked up, and many cardiologists were actually reluctant to make diagnosis in the milder cases. All the milder cases were, mild aortic stenosis, which were not there, or hypertensive disease, or athlete's heart. So in those days, if you had HCM, it's really bad news. We didn't have a defibrillator at the time. That was only for very severe secondary prevention. So it was really like a very exotic disease to be following. And then progressively, it became apparent that this is such a common thing. And now I can't keep up with the referrals. And also we helped establish the concept in Italy, together with Paolo Spirit and other experts. We helped establish the concept that in fact, in a non-selected population, HCM is really not that severe on an average, and it may allow longer normal lifespan, and sudden death is definitely much more uncommon than previously thought, and that a lot of people can really have a reasonably good life or even a very good life with the disease. So this has helped change the perspective a lot. Of course, many problems, many patients with severe disease still emerge and still have the troubles to be there are very, very important troubles. But in fact, overall, the disease, anytime we look at the stats, it looks as though the mortality rates are going down rather than up.
I think that's really interesting. It's like a 23-year look back or so, and I think we have come a long way in HCM, understanding prevalence, understanding severity of disease. So help our American viewers and those from around the world understand the healthcare system in Italy a little bit. And if somebody from Italy is watching now and they're not in your region, how do they get to somebody with your experience and knowledge? So first the healthcare system and then the referral system.
Yeah, I mean, there's pros and cons because we have a national health system. We've had it for many, many years. So the nice thing about the Italian system is that patients really don't have to pay. They pay only a minimum quota of their visit, which is in the range of $30 to $50 for that, including everything, echo and everything. And even if they do MRIs or complex scans or procedures, they pay virtually nothing because it's all out of taxpayers' money. Access is free, and of course the cons is that there's a waiting list, so that sometimes we do have to wait a little bit for referrals unless there's an urgent referral. There's like a 3 to 4 month wait, but anyone from any region can just ask for a referral and come, and they have to have a request from their referring physician. That's all it takes. They can contact us by email or by telephone on their website. So that's really an easy, and that makes it easy to really study the families, for example, because everybody can afford to come, and we can design our flow charts not based on economical issues, but just on slot availability, which is good. We never took money with patients. That's the nice part. The bad part, of course, is that resources are limited, and there are things that are increasingly difficult with crisis.
Right. Yeah. It's a different system, but they both have problems. So patients now know how they can get in touch with you, and we will be adding your center as well as others internationally onto the HCMA website in the coming year. We're working on getting our international systems up and running. I took a little time off a little while ago to get myself better, so now I can get all these things done that I wanted to get done. So
we look forward to having you anytime.
Yes, as soon as we possibly can. So let's talk about research in hypertrophic cardiomyopathy and some of the things that you're currently involved in.
So we have performed a couple of trials. I was actually involved in first person in a couple of trials that have just ended on trying to tackle a novel aspect of HCM. Many people don't know that HCM is a structural heart disease, so it's a heart muscle disease, but it's also a channelopathy. So in the sense that there are secondary changes in the little molecules on the membrane of the heart that actually trigger and transmit the electrical signal that makes the heart contract. So by acting on these channels, you can actually improve a lot of the parameters you have in vitro in the lab in heart muscle from taking surgery from patients. We were able to show that a drug called ranolazine could in fact improve relaxation and also the metabolism of these cells. And we have run a randomized trial hoping to show that this would improve functional capacity in patients with HCM on cardiopulmonary test. Unfortunately, this was not the case. We could not show a significant improvement, but we did show that the BNP went down and arrhythmias were much more infrequent in patients treated with ranolazine. And in clinical practice, there's definitely patients who do respond to the drug very, very well. Keep following up on that, we had Gilead developed a super ranolazine called aleclazine. We performed another trial on that was also randomized international, quite exciting in design, but that unfortunately was not fortunate. And the molecule was sort of killed in its development because of side effects in other studies, not in HCM proper. So this sort of left us a little bit disappointed. But first of all, we established the concept that international trials can be done in HCM, because many people still think you can't do trials in cardiomyopathies because they're too rare, and this is not true. Particularly if we have large registries or you have the HCMA helping you out, you can now do properly designed large international randomized trial and get all the evidence you need for any treatment that you want to test. So now we need to find new treatments. So right now I'm involved in the mavacamten story, which I believe you have told viewers about in the past. It's a very exciting new drug that promises to actually do what drugs usually don't do in hearts. So you're actually trying to power hearts down, which is the opposite of what our drugs usually do in other cardiomyopathies, other cardiac diseases. But because HCM is a greedy heart, is a heart that's consuming too much energy, it's a hypercontractile, at least in its early phase. By tuning down this energy, you may save some energy for the future, make the heart last longer, and reverse some of the abnormalities that are in the HCM heart, including obstruction in the short term and possibly in the long term, fibrosis. So this is really an exciting thing that's coming up, and we are looking forward to that.
That will be a very interesting and exciting international compilation, and I suspect that we will find out a lot more in the next 24 months or so about what it's going to look like, and I know a lot of people are very excited about that. Are there other areas of research, either from your own hands or through your colleagues, that you find interesting or you think we should be looking at more closely?
Oh, absolutely. We just had last week, we had a large meeting in Florence. I organized a meeting with a local chief of pediatric cardiology. So I think children are the new frontier. Children with hypertrophic cardiomyopathy. Of course, HCM in children is difficult because if the children are very small, there are often many rare causes of metabolic diseases, not HCM proper, that can cause the disease. And as kids grow older, though, classic HCM is the standard. We still know very little about risk in children and how to identify high risk and how to treat these little patients. So I think that this is a new frontier. We have a paper in press in JAMA Cardiology where we identified some markers of risk in children. Our children now, some of our children are now grandparents because we had charts this big. We have followed patients for like 40 years now, some of them. Mm-hmm. I wasn't even graduated, of course, at the time. And so it looks as though the risk markers in children are slightly different from the adults. Genetic testing may be more important than it is for adults in identifying high risk. Hypertrophy, the massive hypertrophy may be important, but it's not the most important thing. Ischemia may be more important. And symptoms. If a child is asymptomatic, he or she has much less risk than we believed. Whereas if there are symptoms, that probably is quite an important thing to pick up in risk scores. And together with the London group, with a lot of other European centers, there is now a large registry being collected in London to establish a sudden cardiac risk score for sudden cardiac death risk score in children, which will hopefully be developed in the next few months.
That sounds exciting. I'd be curious to see a copy of that article. Hint, hint. Send it over. I'll
send it.
I'm very curious about that because it is a very complex issue. You know, do you put a defibrillator in a young child? What are the risks of those defibrillator changes over a lifetime and those leads over a lifetime? And if we could identify which parents could be reassured that their children were at low risk, I think we would be all a lot more comfortable to sleep at night.
Absolutely.
A woman who had a 10-year-old implanted with an ICD who's now 22 and doing very well. So it's a tough question for a lot of people to answer.
And talking about that, I mean, the other field where we're quite interested and we have published something is the subcutaneous ICD. We are very interested in that because that is, of course, very appealing in very young patients because there's no wires in the heart. Everything is totally removable. And so it is quite appealing. We have published a paper showing that, however, HCM patients have a very funny ECGs, and sometimes when you have to go screening for SICD, and if your morphology is very strange in the ICD, the machine may not be able to pick the signal right. We have shown that HCM patients may be at higher risk of not qualifying for the SICD, so that new algorithms need to be developed for that. So this is another area where we are engaged.
I'm hoping, as I'm sure you are and many of our colleagues, that the SICD gets smaller and smaller over time because they are still rather large devices for a smaller body frame. And if we can make them even smaller and not be in the heart, we're win-win. And then maybe we can put more devices in when we need to.
Yeah, absolutely, yeah.
Very helpful. So I wanted to take a minute today to discuss medical management of HCM. And interestingly, I just got off a call right before we started our interview with somebody, and I'll give his scenario. So somebody with a mid-cavity obstruction and cavity obliteration is evaluating medical options, and their heart rate is around 55 resting. is this somebody who we should be trying to push on a beta blocker? Should we try a calcium channel blocker? Should we try Norpace? Where do you think somebody should go, and what are the benefits of different types of drugs in HCM?
Well, so you started with the most difficult case, of course, because mid cavity. I mean, there's many patients with mid cavity and mid apical cavity sort of hypertrophy that may go well or not well, depending largely on the cavity size. So if you have mid cavity obstruction and the real very thin, very small mid to apical cavity size, that's usually associated with a restrictive pathophysiology, how we say. So it's really very difficult to fill these hearts with blood because the cavity is so small, and their output will be small no matter how many drugs and whatever you give them. So in that case, if the cavity is really very small, that's hard to manage. And symptoms, in one case, a patient with very severe hypertrophy, we had Sir Magdi Yacoub have a very deep myectomy, for example, transapical as well, and that worked out well. In other cases, it may be very hard. I mean, you may need transplant if symptoms are really very, very bad. But if the cavity is relatively preserved, if you have a cavity that's reasonable size, then you would probably treat it medically as you would treat outflow obstruction. So beta blockers, we have a preference for nadolol usually because that's so well tolerated and potent, and especially in younger patients. And then disopyramide definitely could be an option on top of that. And you can use whatever you have to slow the heart, but also to reduce the strength of contraction and get rid of the obstruction. It's not easy, but sometimes you succeed with that. We
were discussing yesterday your choices in beta blockers of nadolol and atenolol, which are not used as commonly here in the United States today, but I think maybe they should make a comeback. And maybe
yes, I agree. I mean, beta blockers are not all the same. So we have, I have a different feeling for different beta blockers. For example, carvedilol usually is only limited to end-stage patient with systolic and dysfunction. Bisoprolol is this sort of beta blocker you would use if you need very small doses in somebody who doesn't really have much, maybe just to control exosystole in somebody who's young and thin, and you want to go with very small doses to start with. It's also got a good acts well on anxiety because it goes through the blood-brain barrier, but it's not very very effective on obstruction in our experience. In my experience, the best two beta blockers for obstruction are atenolol, which I would favor if somebody has asthma because it's selective, or if somebody is hypertensive because it's a good antihypertensive drug. Nadolol is like more a universal beta blocker in HCM because it's very good on arrhythmias. It's good on obstruction. It's a one-day drug, so it's good for young people who don't want to be taking tablets every 12 hours. And it's potent and well tolerated. Metoprolol, I don't use very much in HCM because it's not as good as the others, I think. But that's my personal take, so it's obviously there's no data. Others will be happy with metoprolol.
I can't wait until the new HCM database is ready and I get to share it with my research colleagues, because about 70% of the HCMA population is taking metoprolol.
Well, it's a great drug for if people use it. I have nothing against, but I just find nadolol to be better. I'm biased. That's my personal bias. So other people will be mad at me for saying this. Yeah. I have no hard data. I'm waiting. I'm really dying to have your real world data and see how it turns out.
I can't wait to be able to hand it over, and let's look at this aggregate data and see what we can learn. So outside of beta blockers, which calcium channel blockers do you prefer?
Well, we use verapamil and diltiazem pretty much on the same basis. In the old days when I started, we had Doug Weigel's teaching, and of course it used to be obstructive, beta blocker, non-obstructive, verapamil, diltiazem. Now, really, with the large amount of literature that you have from heart failure on beta blockers, and the very few data that you have on calcium antagonists, we tend to use beta blockers in any case, unless not tolerated. So I sort of limit calcium antagonist use to patients who really can't tolerate beta blockers. Otherwise, I use beta blocker on whenever there's an indication for medical treatment in HCM, I sort of go that first line. I only go to calcium antagonist if beta blockers are not tolerated.
And what about Norpace?
Oh, we use that a lot, and increasingly so. I think it's a very good first line agent. Of course, to control obstruction, but also for atrial fibrillation, because we're very nervous in using antiarrhythmics in HCM unless it's amiodarone. But amiodarone you would like to avoid in younger patients, and you would like to avoid a very long-term use of that. So I think Norpace is a very good start. We actually have data on that as well. We did a studies in vitro showing that in human HCM tissue, there's a very nice actions that disopyramide does, Norpace does, including improving diastolic properties as well as reducing arrhythmic risk in the myocyte. So I think, and the concerns regarding QT prolongation, which is something that scares a lot of the cardiologists, is not very much of an issue if you check patients serially. You rarely have to stop it on that, unless the patient has other drugs on top of that. And you have to warn patients very carefully not to add other QT prolonging drugs on top of Norpace.
Fantastic. So I'm going to pivot this to the fun part of the conversation, the hopes and dreams. And we talked about this in the pre-interview. You know, what would you say to anybody asking you, what do you hope for hypertrophic cardiomyopathy in the future? And it's a broad question, so have fun with it.
Well, I hope to be out of business before I have to retire. That would be, because that means we've solved the problem. I don't think genetic manipulation is going to do that in the very short term, and maybe ever. But of course, we hope to get rid of the problem for good. But in the meantime, reasonably sort of midterm hopes. Well, first of all, is to preserve quality of life in all patients, in HCM patients who are unnecessarily scared from the disease and whose quality of life is worse than it could be, because that's a very common problem. Some patients have a real mild form of disease, and they deserve to be reassured and to have a proper life. But there's still a lot of uncertainty, and they are still sort of leading a life that's way below the quality that they deserve. And then, of course, I would love to have a disease a drug that really interferes with the process of disease. So rather than wait for nature to decide how the long-term course will be in the heart, whether the heart will develop fibrosis, whether the heart will develop dysfunction, to really be able to interfere with this. We know so much about the mechanisms and the genetics. So really be able to have magic bullets, molecular bullets, more than one, I guess, because probably we will need more than one, interfering with the long-term history of disease, rather than what we do now, which is looking after the complications, which we do, I think, quite well, but it's not like intervening early enough we picked so many of the cases early now.
It would be amazing if you had a family history and you have a child coming up, and yes, they're genetically positive, and we're able to give them a therapy, an injection, a drug, and normalize the processing of that genetic variable. That would be amazing.
But I think we're getting there. I mean, that is something that is not out of reach, I think. And I think HCM may actually be the key to solve many other conditions. This is the nice thing about cardiomyopathies. They are a paradigm. So I'm pretty sure that you find a magic bullet for HCM, you will then use the bullet to cure a lot of other diseases like hypertensive heart disease, for example, which affects millions. So I think this is a door to the inner secrets of many cardiac conditions that are worldwide.
Absolutely. So we do have a couple of comments and questions coming in. And by the way, I like your hopes and dreams, and I hope we get to talk about them in another 20 years and say, hey, remember when we said this? We've done it.
And of course, I won't remember because I'll have Alzheimer's by then. But
but hey, you're in neurology. You'll be able to work on it.
Yeah, I hope they have a magic bullet for that as well.
I think they're working on that too. So Elizabeth's commenting that she thinks that you nailed it regarding the beta blocker question. She was switched off of metoprolol for side effects and now on atenolol. Only 2 days in, knock on wood, and she's doing well. So I think the take-home message here is, if you're really not feeling well on your medication, talk to your doctor about alternatives. There's not one way to skin a cat.
We have so many beta blockers that you can really find the one that's best for you.
Okay, so we have a question here. I'm sorry, DeBono. I've never heard that name before. Just recently chiming in on the long QT chat. Are there particular medications that can cause QT prolongation? So what we're talking about is if you're taking Norpace, you don't want to take other QT prolonging drugs. Can you discuss a few of what those drugs might be?
Yes. First of all, it's very important to distinguish. So Norpace doesn't cause long QT syndrome, okay? Because it's different. Long QT syndrome is a genetic disease. So it's a DNA defect, pretty much like HCM. So, and it's a syndrome you are born with. So many drugs prolong the QT, but they don't cause long QT syndrome. It's different. So it says a reversible cause. So many antidepressants may prolong QT, many antiarrhythmics, virtually all antiarrhythmics prolong the QT. So it's a reversible thing. Norpace prolongs the QT. In our experience, if you have a long QT to start with in HCM, Norpace doesn't do much. It prolongs the QT if it's short. So this is why it's really not unsafe, because it doesn't do very much if you already have a long QT. It mostly prolongs the sort of nice and short QTs to a sort of reasonable level. But of course, if you are taking Norpace, there are drugs like antihistamines or drugs for your stomach or antibiotics that may act on top of that and prolong QTs to dangerous levels. Usually nothing happens. But if you're like low on your calcium in the blood for some reason, or you've had diarrhea and your potassium is low, there are very exceptional cases in which you may have very dangerous arrhythmias that are triggered by long QT. They're called torsades de pointes. They may be lethal. So it's very important to stay away from that. It's very rare, but it can occur.
I know there's been a big push here in the United States lately on the ZPak, zithromycin. That it can cause a QT prolongation. They're very rare cases, and I will get, every time an article pops about it, people say, can we take a ZPak with HCM? And I tell them it's normally safe, but you've got to look at the unique situation of you.
Yes, I mean, there are apps now. There are very nice apps that tell you very easily, tell the physician or the patient as well, but it's usually for physicians. So it's easy to, you pull in all the drugs and it tells you whether there's interactions. With people taking more than one drug, it's a common problem. You have many interactions and QT is only one of them.
And it's not DeBono, it's Lindsay. I read, she has her name, she has a Facebook name. So, hi, Lindsay.
Okay.
If you have any other questions, I would pipe them in now. We're going to wrap up here in a few moments with Dr. Iacopo Olivotto from Florence, Italy, which happens to be my favorite town. And if you can see in front of me right now, I'm looking at a picture of the Duomo right in front of me in my office every day. We have a big question coming in here. So, and I will be back there next April, I hope, and looking forward to the next conference. This one's going to take up most of the screen, people, so let's see what we have to say. Kelly had a septal myectomy in April of 2015 and found to have non-sustained VTAC constantly. I already have a defibrillator in place after open heart. They put me on amio 2 years ago and take metoprolol. I can't stay on metoprolol, in my opinion. I live in fear of the arrhythmias becoming daily, and assuming I'm 52, I can't stay on amiodarone for life. Doing what? Right now I'm doing well. Okay, well, I'm glad that you're doing well. My first thing to say on a case like that is I do hope that you are working with the Hypertrophic Cardiomyopathy Association Recognized Center of Excellence. If you are not, please give us a call and we'll hook you up with somebody. But 52 years old being on amiodarone is a bit concerning, and we want to make sure that you have the best management possible. There might be some other options in terms of antiarrhythmics for somebody in these situations. So while, Kelly, we can't talk about your specific case, I'll ask the general question to Dr. Olivotto about what other antiarrhythmic options might be available for somebody with NSVT.
So, well, first of all, NSVT is worrisome, but it is not per se a dangerous condition. It's just a marker of electrical instability. So sometimes, patients have NSVT for a lifetime and never have an event. It's very common to have non-sustained VT. Sometimes better is worse than good, we say. If you have a defibrillator and you have non-sustained VT, I sometimes just put my patients on my best beta blocker and titrate it to the max and take out amiodarone and see what happens. And I monitor them closely, because sometimes that's all it takes. And if it's just a few runs on a non-sustained VT, I just let it be. That doesn't usually affect, and very rarely this actually translates in a major event. If you do have sustained VT, on the other hand, which is not the most common arrhythmia in HCM, sometimes this can be related to a scar. And so if that is the case, you may consider catheter ablation, but that is only something that I would apply in a very, very small minority of patients. I rarely do it at all. So my tip is to check whether your arrhythmic risk really warrants amiodarone, or whether you can just be on a beta blocker, since you have a defibrillator, which is going to protect you anyway.
Right. That's great comment there. Any other questions? Submit them now, or if you do submit them after we are off the air, we will try to follow back up with you, but cannot make any guarantees when we're no longer live. It is currently 12:36 Eastern time, so if you're watching this and you think it's live, look at your clock and see if it's live or not. So ask your questions now. So while I've got you here for another couple minutes, what do you see coming down the pike in terms of collaborative efforts internationally in hypertrophic cardiomyopathy? I think we're a lot further along than we were 10 years ago. So let's talk about where we think we might be going here.
Well, part of this is already happening in the sense that, as you know very well, there are registries now. There are at least two very large registries. One is the European registry that's been set up. Well, that really focuses around the London group, but there's many other centers participating in several initiatives. They, for example, were instrumental in setting up the European sudden cardiac death risk score and other initiatives. And the other one is a transatlantic registry called SHARE, which was spearheaded by Caroline Ho at Harvard, and now includes several centers in North America, Europe, and South America and Australia. We also have Sydney in this registry. We are part of SHARE, and this currently now includes over 6,000 patients with a hypertrophic cardiomyopathy. The nice thing about this registry is that it's not just people lumping together data. It was actually a centralized system where every single variable was discussed and defined, where the genetics was sort of discussed and adjudicated centrally. So it was really quite a lot of work, 2 years of preparatory work to make sure we were not comparing apples and pears. So it's really now beginning to produce a lot of data, and hopefully will be the backbone for upcoming trials. We really hope that we can sort of eventually join forces with HCMA, with any other center who's willing to join. And we really need thousands of patients in order to come up with the correct candidates for single drug trials, for example. Trials can't be done on all comers. You need subsets. You need specific subsets with inclusion and exclusion criteria. Unless you go to start with many thousands, you will not be able to pick up the few hundreds that you need for the trials, for example. This is just an example. Then, of course, there's many other things that we can use registries for. Sudden death risk score, heart failure risk score, assessing longevity, and also real life, real world safety and efficacy of drugs, for example, devices, operations.
Exactly. Well, I'm very excited as to where we are today compared to 10, 15 years ago in terms of collaborative efforts. Technology has caught up with us. We've always had friends across the oceans, and now we can collaborate with everybody a lot easier due to technology in part. So looking forward to a lot more collaboration and a lot more answers coming up soon. Amy's popping in saying thank you. You're welcome. And I'm going to end the broadcast now, and thank you very much to Dr. Iacopo Olivotto, and hopefully we'll get him back here again to discuss the upcoming trial in mavacamten, and the HCMA will be working closely with you on that one, and we thank you for your time today.
Thank you, Lisa. Thank you to everybody.